Welcome to the webinar, 7 Strategies for Successful Case Management. This is Royce from the Home Care Alliance. The webinar is given by Cheryl Pacella, and I'm going to turn it over to her right now.
Thank you, Royce, and I'm very happy to be with you folks today to talk about a topic that is very near and dear to all of us. I think everyone who works in home care struggles to some degree in terms of what can we do to improve case management. So what I'm going to do today is to provide you with some strategies which I feel are critical for successful case management. Just a very little bit of background information. I personally have been in home care for about 24 years now. I started back in 1990 as a per diem nurse. Over time, I took a position as a weekend nurse, and then I took a position as a primary nurse, and I could see the evolving role of case management over those years. Eventually, I took a position as a nurse manager, and that was followed by clinical educator, quality improvement coordinator, and even director of a small home care agency. And over time, I realized how important case management is and how much I really didn't understand it when I began my career in home care. I used to say to people that I had 5 children, and when I took on my first assignment as a primary nurse, I added 20 more people that I was responsible for. I didn't really understand back then all of the things that you need to know about case management, and I have a much better understanding of that today. So this program, we are going to offer continuing education. So when you complete the program, you can submit an evaluation, and you will receive a contact hour for this segment. So the objectives for today's program, at the end of this session, I'm hoping that participants will verbalize the rationale for managing a caseload of patients effectively. I would like you to be able to identify 2 to 3 strategies for determining visit frequency. And that's something that new nurses frequently struggle with, so we'll talk about that. And finally, at the end of the session, participants will describe how to determine whether a patient should be discharged or recertified. And that's really important nowadays in terms of trying to decipher what do we do to best meet the needs of the patient, especially in light of all of the intense scrutiny now from the Medicare administrative contractors and CMS. So as I said, keep these objectives in mind and be sure to complete your evaluation at the end of the segment. On the next slide, I'm going to talk a little bit about who I feel is an appropriate target audience for this session. First of all, obviously new nurses, keeping in mind that nurses who are new to home care are perhaps coming from a hospital environment where they may have been accustomed to taking care of maybe 4 or 5 patients, or perhaps more depending upon what shift they worked. New nurses could also be coming from school, where their clinical experience at school, they only had exposure to a couple of patients. So for new nurses, I think it is very difficult for them to wrap their minds around the concept of case management. Old nurses as well. And the reason I say that is because sometimes we know that old habits are hard to change. Back in the day, I remember working with an acute care team and a chronic care team. We would keep patients on indefinitely just in case they went back into the hospital. Also had management and evaluation of a care plan. So back in that day, we didn't really pay too much attention to visits, and we basically were being paid fee for service. And then along comes prospective payment system, the HMO mindset to get in and get out, And agencies even had HMO teams where they had clinical staff that were specifically trained to case manage effectively, get the prior approval, do what needs to be done, make sure that the patient is safe, establish joint goals, and then discharge the patient. So now we need to take that HMO mindset and apply those strategies to just about all patients. Now, another member of the target audience would be the frontline managers. And as a former frontline manager, I know that these folks struggle with a fine balance between staffing, productivity, covering patients, getting new admissions, and determining when it is appropriate to discharge patients. Clinical educators also need to be involved in case management because they are responsible for helping to train staff and to periodically review some of the best practices with clinical staff. And finally, but certainly not least, quality improvement staff. These are the folks that need to make sure that the services being provided are reasonable and necessary to meet the needs of the patient. And nowadays, even more importantly, we need to make sure that all of the visits can stand alone and demonstrate skill, and that those visits will be reimbursable. So in today's program, I have a couple of documents that I have added. You obviously will have the PowerPoint slides, but I have also included a tool to help you calculate home health aide hours. And that is especially helpful when we are admitting patients whose caregivers and loved ones think we provide a lot of home health aide service when in fact the patient might not need that much service. And this is a tool that can help to calculate those hours, not only for the agency's benefit, but also in terms of educating the families about what is realistic. Finally, based upon my experience working with a number of agencies, I know that clinicians struggle with making the decision whether to recertify a patient or to discharge a patient. So I put together a tool that can be used to help answer those questions. So those are the handouts, and we'll spend more time talking about them a little bit later. So why is this whole topic of case management so important? We know that new nurses and, like I said, seasoned nurses struggle with managing a caseload of patients successfully. I'm going to share with you today some benchmark numbers that we will talk about that will help agencies in determining what is appropriate for a caseload size and what is manageable. But in terms of providing care to a patient, we need to focus on outcomes and patient satisfaction. We know that the outcomes are very important to our referral sources and other providers in the community, and they establish ways for a home care agency to benchmark itself against their competitors and also to make them stand out. So another question that new folks often ask is, how do you manage your and your patient's day-to-day schedules? Where do you start? And hopefully I'll give you some guidance regarding that today. How do you determine visit frequency based upon risk? Should you recert a discharge? How do you decide when it is appropriate to reduce visit frequency? How much home health aide service does your patient really need? So these are some of the questions that will be addressed during today's program. We are all being asked to do more with less time, less resources, and that's why it is so important to be efficient and effective in the delivery of our nursing care. And as I said, we want to make sure that our publicly reported outcomes are positive. Agencies use this data to market themselves, and home care is getting extremely competitive. I remember years ago, there were only 90 home care agencies in the state of Massachusetts, and that was back in the day with working with the QIO community. We would go out and work with folks, helping them to decrease hospital readmissions. Now, I know for a fact that there are greater than 200 home care agencies in Massachusetts. But with all of the mergers and acquisitions and what is going on with face-to-face, I anticipate that a lot of these numbers are going to begin to fall down, and we'll see fewer agencies. So the next slide basically introduces you to what I call strategy number 1. Know your agency. I like to have the picture of Dorothy's ruby red slippers because my motto has always been, there is no place like home care. So the first strategy is to be aware of your organizational culture. What is the mission of the agency? What is the vision? What are the values? And are these known amongst all clinical staff? Next, it's important to have a firm understanding of each individual's role. And this can be from clerical all the way up to CEO. One of the best practices I have seen is to have the employees on an annual basis review their job description to make sure their job description clearly matches with what their expectations are. And over the years, I've seen a lot of controversy over staffing models. What works best in terms of structure for the agency? Does a not-for-profit model look different than that from an agency that is for-profit or proprietary? These are just some of the things to think about. And I have had the opportunity to work on both sides of that issue. And I can tell you that, for example, in the voluntary not-for-profit side, we tend to manage our patients without too much of a consideration to the numbers in terms of average daily census, whereas on the for-profit or proprietary side, I've been in situations where you will have to hire new staff when the numbers go up, but then you also need to let those people go when the numbers start to go down. And different staffing models exist in different agencies, and a lot of it really depends upon the individual job description and what the expectations are of those individuals. We want to make sure that there is alignment between the staff attitudes and the strategic goals within an agency. And as I've stated, we all want to provide quality, cost-effective care that is reasonable and necessary to meet the needs of our patients to keep them safely at home. And that's always been my personal mission as a home care nurse. So again, everybody needs to know what their expectations are, and they need to know where they fit within the organization. And you need to make sure that you have an organizational chart that is current. People need to know who is responsible at the senior management level within an organization. And we are all moving towards a pay-for-performance model, so we need to make sure that we are operating efficiently and effectively and providing quality care to our patients. So along these lines, you need to ask, what are your numbers? And I think of these in terms of the average daily census, the number of clinicians per team, what is the ratio or the mix of full-time versus part-time versus per diem staff? Does your agency utilize contract staff? And what is the average caseload size? And we'll talk a little bit more about productivity. But when you look at your organization, everything seems to hinge upon the average daily census, because the average daily census helps to determine how many teams there are within the agency. But also consider, are there any specialty teams? For example, a maternal child health team. Do you have a team of nurses that specialize in psychiatric nursing? Has your agency provided a niche in the community related to a particular area? For example, do you have a proven, successful heart failure program that can be used as marketing to entice new patients and referrals? How do you manage your orthopedic patients? Do you have any delays for therapy getting in on some of these cases? Do you have outstanding therapists that provide high-quality care and good outcomes for those types of patients? But we do all tend to shy away from discussing productivity, but I really feel that it has to be addressed. In terms of caseload size, Bozzi and Associates conducted a study in 2013 over 6 months. They surveyed the CEOs of over 1,100 agencies across the country. And what they found is that for-profit agencies typically have a caseload of 27 or more patients. Not-for-profit agencies typically have a caseload of 20 to 23 patients. And talking about productivity, the majority of home care agencies report an average productivity of 5 patients per day, and that's with admissions counting as 2. You need to think about your organization. Do you have admission nurses? What impact does travel time have on productivity? Do your nurses rack up a lot of miles, or do they spend a lot of time sitting in traffic? These are some of the considerations that you need to think about. What Bozzi also reported is that the majority of home care agencies do utilize point-of-care systems. They estimate that close to 60% of the staff complete at least half of the documentation in the patient home. And I know, having gone on joint visits with a number of clinicians, it disturbs me when they still walk in with a piece of paper and a notebook and write down everything, stating that they will get back to the computer later in the day or in the evening. And I think to myself how much more efficient it is to get that documentation done in the patient's home as close to real time as possible. So also what you need to consider is, if your clinicians have high volume caseloads, how are they effectively providing quality care? Can they successfully manage high volumes of patients? Can they discharge appropriately? Do they recertify appropriately? Is there any lag or delay in the entry of their charting and documentation? And what impact does a high caseload have on patient satisfaction and outcomes? So those are all some things that you need to understand. So again, this is basically some of the information that we had just talked about, but I want you to understand why it is so important for you to know your numbers. Now, clinicians, I often feel, don't really understand the big picture. I, as a staff nurse, never really appreciated the average cost per nursing visit. I certainly do now, but back then, I think I was making $9 or $11 an hour, and the home care agency was charging $80 per skilled nursing visit. And I know now, I see the average nursing visit is up around $150, and the physical therapy visit is higher than that. So as we transition from fee-for-service to prospective payment, everybody had to wake up and pay attention to these numbers and understand why it is so important. We need to consider the triple aim. There are 3 goals for practice. We want to provide high quality but at a lower cost, and we want to have high patient satisfaction. This really all begins and ends with accurate and timely OASIS assessments. We know that OASIS was originally designed to measure outcomes and determine how well patients did when they transitioned from point A to point B. And public reporting now is very important. And that's why it's so critical that the OASIS items be answered properly. And as I have emphasized, patient satisfaction, referral source satisfaction, and think about your own staff satisfaction. People that are overwhelmed and overworked might have poor performance and might not be functioning as well as they can. I know that Bill Dombey was in Boston a few months ago, and he talked about all the cuts that have taken place over the years, but also the opportunities. And he said that we basically have become more efficient, and we have improved the quality of care with decreased resources and decreased reimbursement. Now, the next slide basically is an overview of some of the information about OASIS. We know that prospective payment system went into effect in October of 2000. And basically, as I said, it was designed for quality, but it was tied to reimbursement. And when OASIS became tied to reimbursement, that's when some of the scrutiny really ramped up. If you look, for example, at the HERG, the Home Health Resource Group, and that is used to calculate the case mix weight and how much money the agency will be reimbursed for the care that is provided. That's why it's so important to answer OASIS items accurately. We talk about case mix weight, the public reporting, as I said, with Home Health Compare. I know that years ago, we used to pay attention to the numbers in terms of the fee-for-service and that way. But nowadays, we calculate the reimbursement based upon the HERG or the case mix weight. And there was some rebasing that took place this past year. And the base rate for C1, F1, S1, the clinical 1, F1 functional, S1 service domain was $2,869.27. But with the rebasing that took place as a result of the Affordable Care Act, a C1, F1, S1 is now reimbursed at the rate of $1,739. So in fact, the rebasing took our case mix weight from 1.3 to 1.0. And that's why it's so important that we pay attention to all of the OASIS items, making sure that they are answered correctly. We also know that there is intense focus right now on home care. The Office of the Inspector General has reported on widespread fraud and abuse. And basically, everyone's records now are being scrutinized for homebound status, medical necessity, a complete and accurate face-to-face encounter, and the therapy assessments. Now it is more important than ever that we pay attention to all of these areas. Also, just wanted to share with you in terms of numbers, the Medicare Payment Advisory Commission, also known as MedPAC, reported that 3.4 million Medicare beneficiaries received care in the year 2011, and that care to those patients cost $18.4 billion. So home care is a huge industry, so it's no wonder we've seen the increase in growth, and especially as the baby boomers come along. So again, this is just summarizing the impact of rebasing. And I want to stress once more, it is critical to pay attention to all OASIS items. So strategy number 3, it all starts at intake. Think about the types of referrals that your organization is accepting. We know that we cannot accept referrals when we do not have the resources to meet the needs of the patient. And I want to share with you an example that illustrates customer service, because I feel that this is important to keep in mind. When you think about this, if someone calls in a referral for a patient who has psychiatric needs, if you don't have skilled staff in that area, then you will have to deny the referral. But I think it's helpful to keep the names of agencies that are nearby that do have a psychiatric nurse or a psychiatric team. That way, you're forming a good relationship with your referral source, and they will call you in the future when they have a patient who is more appropriate to the types of services that you can provide. We all know about the train wrecks, too, and I used to dread those Friday afternoons when you would ask yourself how many agencies were called and said no before we got this telephone call. I know a lot of agencies have a policy or a practice whereby they do not say no to any referrals. But you also need to think about how is your agency staffed. I think nowadays we're seeing more and more agencies that are staffed 7 days a week, 24 hours, 305 days a year. Are you prepared to take those off-shift referrals? And that's something to consider because the majority of admissions, it seems, come in on the weekends. Perhaps your staffing on weekends should be no different than the staffing pattern Monday through Friday. And remember, it's all about customer service and meeting the needs of your referral sources. So these are some of the questions to consider. What does the patient need? How soon does someone need to visit the patient? Do you have adequate staff? Would there be a delay for therapy? Does the patient have any special needs? And is this potentially a high-risk patient? I used to love the hips and knees patients because we know they are typically limited in nursing, high on therapy, high on reimbursement, and on caseload for a relatively short period of time. And the bonus is they typically have good outcomes. Plus, I would never worry about trying to argue one of these cases with an Medicare administrative contractor. Those cases are less likely to be denied. So let's talk a little bit about the Medicare criteria. Is the patient homebound? We have a new definition of homebound, which I'm going to share with you. Are the services skilled? Are the services intermittent? Is the patient under the care of a physician? Pay attention, I will caution you, to the MLN, Medicare Learning Network Matters updates. You can sign up for their email notifications at www.cms.gov. That way you can keep current with some of these changes that are going on. So in regards to the homebound status, here is the new guidance. There are now 2 criteria that must be met to meet the definition of the patient being confined to home. The patient must either, because of illness or injury, need the aid of supportive devices such as crutches, canes, wheelchairs, and walkers, the use of special transportation, or the assistance of another person in order to leave their place of residence, or have a condition, for example, a medically contraindicated reason such as a draining wound, such that leaving his or her home is medically contraindicated. There must also exist a normal inability to leave home, and leaving home must require considerable and taxing effort. So what is case management? I actually got this definition from the Case Management Society of America. Case management is a collaborative process of assessment, planning, facilitation, care coordination, evaluation, and advocacy for options and services to meet an individual's and family's comprehensive health needs through communication and available resources to promote quality, cost-effective outcomes. So now let's talk about what goes into formulating a plan of care for your patients. These are some of the considerations. Scheduling visits that need to be customized to meet the needs of the patient. Ranges are indeed acceptable as long as they are based on the needs of the patient. That question seems to come up a lot, and I typically will see skilled nursing visits written as 1 to 3 times a week times 9 weeks. Therapists, for the most part, are more structured in terms of how they set up their visits. But again, the visits need to be based upon the needs of the patient. You can't say, I'm going to see the patient 3 times this week, and then I'm going to see the patient just once next week because I have some vacation time. Or you can't automatically go from 1 time a week back up to 3 times a week without any rationale for doing so. The visit frequency needs to be based upon the needs of the patient. So you also want to remember that you want to taper your visits according to the needs of the patient. And be careful not to, quote, lose patients. I tell people that when I admit a patient to care, I want to plot out the visits over the 9-week episode of care. And the reason for doing so is if I know, for example, I'm going to use this, if I was to win the lottery tonight, then I might not possibly show up at work tomorrow. And you don't want that patient to get lost in the shuffle or to fall off of someone's calendar. That's why it's important to schedule your patient's visits out over a period of time. I know the question comes up frequently about dealing with absent or missed visits. If your visit frequency falls below the MD orders, then you need to communicate that to the doctor's office. And I have literally seen people add statements on their plan of care to the effect, visit frequency may be decreased for patient's refusal, if there is something to do with the weather or, a weather emergency, for example, a snowstorm, or things like that. Really, when you think about it, you want to pay attention to these. Even if the patient has a doctor's appointment and the visit frequency falls below, you still need to notify the physician. And there are a couple of ways to do that. I've seen people create a simple form and then they fax it to the doctor's office to let them know that the visit frequency fell below for whatever reason, and the patient did not get seen as they were ordered. But keep in mind, if you write your orders 1 to 3 times a week, you do have a little bit of wiggle room with that. So within your agency, who is looking at the scheduling and who does the scheduling? I know that in some agencies they have clerical staff that set up the scheduling, and in other agencies it's strictly done by the clinicians. But the majority of home care agencies, it appears, use a combination of office staff and supervisors. So considerations for high-risk patients, and we're going to talk a little bit about this. I want you to remember that you can identify who your high-risk patients are simply by looking at some of the data that is collected on the OASIS. And I know that some of the software systems can generate a report that highlights those high-risk patients. I would say to you that any patient with a frequency of going in and out of the hospital multiple times over the course of a year would be high risk. I would say that a patient who has heart failure for most home care agencies is also high risk. So what do you do different for some of these high-risk patients? You need to take a look at what we call front-loading visits. And by front-loading visits, we take a look at the number of visits per episode. Say, for example, the average patient has about 17 or 18 visits per episode, and we move some of those visits up into the first couple of weeks. And the patient would be seen more frequently in the first couple of weeks, and then the visits would gradually taper off to the point where the patient might be seeing a nurse perhaps even as infrequently as once every 2 weeks. Another consideration in regards to high-risk patients, utilize phone calls. Make telephone calls to these patients in between visits so that you can determine whether or not they need an extra or PRN nursing visit. Just a quick word on PRN visits as well. When you write your orders for PRN visits, make sure that they are not only quantified but qualified, meaning a patient who has a wound may have PRN visits for a deterioration in the wound, or a patient, for example, who has heart failure may be having PRN visits for exacerbation of heart failure. A patient with a catheter may have PRN visits based upon the need for problems related to the catheter. So think about all of these things when you're trying to schedule and determine how many patients and how many visits per patient. Another thing to consider is telehealth. I know that when FOSI conducted their study, they determined that 70% of the 1,100 agencies did not offer telehealth. But I personally feel that telehealth monitors are a way that agencies can effectively manage the care of some of their patients and maximize their visit frequency to best meet the needs of the patient. So you can consider all of these different things. So this is an example of caring for a patient with congestive heart failure. At start of care, would the patient benefit, as I said, from telehealth? How likely is it that this patient will return to the hospital? Perhaps very likely if they are in and out of the hospital many times. What factors contribute to this patient's risk for rehospitalization? Is it because of medication issues? Is it because the patient doesn't have a scale? Is it because the patient isn't eating properly and is experiencing fluctuations in his or her weight? Is it because the patient has edema that needs to be adjusted with medications? Things like that. So how often does this patient need to be seen? We've talked about front-loading visits, seeing the patient more frequently in the beginning, and then tapering visits. But what other disciplines should also be involved in the care of this patient? So you can take a look at patients with different diagnoses and different reasons for home care and try to determine what is best to meet the needs of the patient. I do want to warn people, though, about not overwhelming patients sometimes, because if we have a lot of disciplines, you want to make sure that they're talking to each other and spacing out their visits. So consider a patient who has joint replacement. Something to ask, did the patient come from a rehabilitation facility? If so, the patient might not need to be seen as frequently as someone who was just discharged from the hospital. I know that some hospitals discharge fresh hips and fresh knees in just a couple of days, and those patients coming out of the hospital under those circumstances really have a different plan of care than some of these patients coming from a skilled nursing or rehab facility. So you need to identify what are the patient's skilled nursing needs. Very frequently, it could be pain assessment and management. It could be phlebotomy or INRs for monitoring their blood for Coumadin or whatever, and then what are the patient's physical therapy needs. I think that the therapist, including the occupational therapist, are pretty skilled at identifying up front what is realistically necessary to put in place to serve these types of patients. So strategy number 5 is effective care coordination. I've talked a little bit about the role of nurses and therapists in these different types of scenarios, but it's important that these folks talk to each other. Case conferences. What is your agency's policy in regards to case conferences? I've seen successful agencies have case conferences that are very structured, and they have a schedule whereby the case conferences occur automatically every 2 weeks. And that's multidiscipline, where some of these complex, high-risk patients are discussed. It's also an opportunity to talk about patients who may be recertified. Also, it sheds light on what are the extra special needs of patients, if there are psychological needs, if there are social worker needs, things such as that. So there is a real benefit to having regular case conferences with the disciplines involved in the care. And even with that, people need to document the results of these case conferences and the communication with other disciplines. So it's important to just make an entry into the clinical record. I know that some of these software programs even have, for example, a way to identify this is a case conference note as compared to a regular narrative note. So think about these things. If it's not documented, it's not done. We need to have documentation to the effect that these case conferences and care coordination are taking place. You need to think about a process for internal and external referrals. And I talk about this in terms of if your agency, for example, has a nutritionist, you want to make sure that there's a process in place to make a referral to the nutritionist for someone who perhaps is struggling to manage their diabetes, or someone perhaps has problems with a renal diet. And then we do make external referrals as well to programs in the community that might help people, whether it's helping to set someone up, for example, getting Meals on Wheels, the community resources through the ASAP, the Aging Services Access Points. And as we progress our patients over their time with us, we might want to consider transitioning their care so that the home health aide is eventually replaced by a personal care attendant in the community. So again, it's really important to have good care coordination. And I think people working together need to have a discussion about who is going to be responsible for helping to oversee the plan of care and making sure that all of the patient's needs are indeed being met. So formulating goals, I like the acronym SMART goals, and we know that each of the disciplines has their own goals for the individual patient. But keep in mind, the goals need to be formulated in conjunction with the patient. These are not the clinician's goals. These are the patient's goals. I'm going to share with you a short story of a patient who had a referral for physical therapy. And she also had skilled nursing. But when the therapist came to visit the patient, who was staying at her daughter's house, the therapist said, "Okay, Mrs. Jones, can you tell me why do you think I'm here?" And the patient knew that having had a joint replacement, the goal was to get her walking and ambulating better. And so the patient even said to the therapist, "I really want to get back to my own home." And the therapist said to her, "What will it take for you to get back to your own home?" And she said, "I'm going to need to climb upstairs to get up to my bedroom and to the bathroom." So there you have it. The therapist was able to establish, working with the patient collaboratively, what are the goals for this patient. and those goals of the patient helped to structure the therapist in terms of what she needed to do. So you also need to periodically reassess the goals, and this is important especially as you come to the end of an episode of care. And like always, document the progress that is being made toward goals or the lack of progress toward goals. So this is the SMART acronym. SMART stands for S, specific to the patient, measurable, achievable or attainable for A, realistic for R, and finally timely for T. And I know, for example, therapists are really good at documenting benchmarks and points that they want the patient to achieve that would indicate that they are progressing and they are moving towards their goals. And now especially in light of the fact that they need to document objective reassessments at visit 13, 19, and every 30 days. So strategy number 6, I introduced this at the beginning of the segment. Basically, it's a tool to help home care agencies determine how many home health aide hours a patient needs. I know that years ago, I had worked with an agency and we had utilized what was called the cadet tool. I haven't been able to retrieve that, but I did want to share with you another tool that I found. And this one, believe it or not, I actually got from Google. And when I looked at the computer, I found, I entered, tool to calculate home health aide hours, and it came up with this document. And this was retrieved from www.homehealthinteractive.com. And the title of this document is Give Clinicians a Tool to Determine the Number of Aide Hours. Now, I did not change the M items for this, but you can clearly see bathing, dressing, and shampoo, then elimination, ambulation, transfer, etc., etc. This tool is actually a couple of pages long, but if you calculate the score in each of these sections, you can use that raw number to help you to determine how many home health aide hours or visits does your patient need. For example, the scoring for Medicare, if the patient scores an 8, that means that patient is pretty independent and doesn't really need personal care. Whereas if the patient scored 9 to 15, minimum assistance would be required, and the home health aide would typically see the patient, I would say, perhaps 3 times a week. So things like this. And we know that some of our patients, particularly those who are bedbound, then those patients perhaps need to have more home health aide service. And it's a great way to help you determine the home health aide hours. Just a word in regards to home health aide hours as well. Sure that the home health aides, that there is supervision documented in the patient's chart. And it really is important that the clinical staff talk to the home health aide and get feedback from the home health aide in terms of how the patient is progressing. And my recommendation in regards to home health aide supervision is to have the skilled nurse document home health aide supervision every visit. That way you know that you will not have to worry about the every 2-week requirement. And keep in mind that as you taper professional visits, whether they're skilled nursing or therapy, also consider tapering the home health aide service. I hate to tell you how many times agencies have been in the situation where the skilled nurse would discharge, the physical therapist would discharge, and lo and behold, the home health aide had not been notified and continues to see the patient. And we don't want that to happen. So finally, I come to strategy number 7. Strategy number 7 is in regards to deciding whether or not to recert or discharge patients. And the way to help decide that is you can utilize the tool that I have included as a handout. It's called Decision Tool. And basically, when you look at that document, it has some questions. And I can tell you my best practice has been at the time of recertification, the clinician needs to meet with his or her clinical manager and discuss the case and determine if it is appropriate for this patient to be recertified. And that's one of the reasons why I put this together, is to help people. You need to reassess, will the services that are being provided meet the Medicare criteria? Make sure that the documentation supports that the patient is homebound. Definitely take a look at, have there been any changes in medications in the past 30 days? Has there been a change in the treatment plan? For example, your patient might have wound care. Was there a change in the treatment plan that is documented? Has the patient been hospitalized or been to the emergency room? These are some of the considerations that you need to think about when it comes time to either recertify or discharge the patient. Please make sure that you document the progress toward goals or the lack of progress towards goals to justify the need for continuing care for the patient. Also think about what are the learning needs of the patient. And I want to point out to you that the Medicare Benefit Policy Manual had been updated this year. And what they did was they took a lot of the information that was in the section under skilled, skilled for nursing, skilled for therapy, and they have very clear guidance in terms of documentation. The reviewers from the Medicare Administrative Contractors, they really frown upon statements such as continue with plan of care, continue to monitor, and then all medications were taught. So I tell people when you're documenting medications, take out 1 or 2 specific medications each time. Don't document all medications were taught. It really is important that each of these notes can stand alone and demonstrate skill. So finally, just to summarize, these are what the 7 strategies are. Know your agency, understand the big picture, remember that it all starts at intake. You need to formulate a plan of care. There needs to be effective care coordination. You need to determine the appropriate number of home health aide hours, and you need to be able to decide when it is appropriate to recertify the patient or to discharge the patient. So I hope that these strategies will help you in your efforts to successfully case manage your caseload of patients. Now these are just some of the references that I had used, and just about anyone can go on to the Medicare site, cms.gov, and look up some information in the benefit policy manuals. But I also, as I said, accessed the Case Management Society of America, and this is a healthcare quality handbook, and I was fortunate to have listened to the webinar that Bob Fozzie had done to provide some of the guidance that I shared with you today. Now, I will take some time to address a couple of questions, and it appears that there are a couple of questions that people have entered. So I'm going to take a moment to answer those before we wrap things up for today. So one of the questions is, do you have suggestions for case conferencing? And one of my suggestions I obviously talked about is having a structured meeting whereby the difficult cases can be case conferenced. Agencies will need to determine what works best for them, but even if you don't have a formal system in place, it's those little impromptu dialogues that take place as people are coming and going that we need to make sure are captured. I think it's important that people have a way of identifying in their clinical documentation system what is a case conference or a care coordination conference. So if you can do that, then you can sometimes run a report to just see how frequently it is being done. And of course, remind people all the time. Include this on your chart review tools. So always pay attention to it. I know that reviewers and surveyors will be looking for that information. All right, I think I have another question, and this one is in regards to recertification. Is there any benchmark data in terms of the number of patients being recertified? And I can tell you that that seems to be all over the place. I've worked in agencies that have a low recert rate, as low as perhaps as 20% or even a little bit lower. And I've worked at agencies that have a high recert rate, as high as close to 40%. But my concern is that CMS and the Medicare administrative contractors are looking very closely at the recert episodes to make sure that they are appropriate to the needs of the patient. Sometimes it depends on your patient population. If you have a lot of orthopedic cases on caseload, chances are those folks are not going to be recertified. But if you have a lot of chronic patients, for example, the COPD, heart failure patients, those patients may go into another certification period. But don't keep them on indefinitely, quote, just in case something happens. Also think about the wound care patients. You know, at what point is the wound care no longer intermittent and it becomes chronic? So if you have those types of wound care patients that never seem to go away, make sure that you're documenting changes to the treatment protocol, wound measurements, et cetera, et cetera, et cetera. And I think I have time for one more question. This one is, do you always have to start at the upper end of the range when you are scheduling visits? And I understand where that comes from. We know that I have said it's perfectly acceptable to write a range of 1 to 3 nursing visits a week over a 9-week period. And the reason I say this is because if you utilize a range, you minimize your risk of falling out of the range. So say, for example, I write my orders 3 times a week times 3 weeks, twice a week times 3 weeks, once a week times 3 weeks. In scenarios such as that, I have a greater likelihood of being out of compliance any one of those 9 weeks. But when you write your orders 1 to 3 times a week times 9 weeks, the expectation is that you do indeed start at the upper end of the scale. So if I write 1 to 3 times 9, I would think that for perhaps at least the first week, I would be up at 3 visits. And then perhaps after that, maybe 3 visits one more week, and then decrease the frequency of the visits. But again, keep in mind, the range can only be utilized based upon the needs of the patient. It isn't because I'm going on vacation, or it isn't because the patient won't let anybody else but me go out to see them. You know, you need to think about these things. It really needs to be based upon the needs of the patient. And with that, I think we're just about out of time for today's segment. So, Royce, do you have any more questions for me?
I do not have any that's come in here, so I think we're doing fine.
Great, great. Well, thank you, everyone, for your participation in today's program. I hope you learned some things about my 7 strategies for successful case management. Here is my contact information. If you would like to reach out to me, I would be happy to address any other questions that folks may have. But once again, thank you for your time on the call today, and please be sure to complete the evaluation. And finally, just as we close, I want you to think about, based upon what you have learned today, what will you do different tomorrow? And be sure to complete the evaluation and return it to Royce. Thank you very much, everyone.
Thank you, Cheryl. Bye.
Bye-bye now.